Save time, I'm going to call the meeting to order. Our first presenter is our State Health Officer, Dr. Thomas Dobbs. We have a new system, so I don't know how. I have no idea how this works. I'm sorry, we have a new sound system, so of course it doesn't work. Not as bad as a computer upgrade, but similar. Our first presenter is our State Health Officer, Dr. Thomas Dobbs. Dr. Dobbs, we know more about the virus today than we've ever known before. And it seems to me the virus is spreading more than it ever has before. Can you explain to us why?
Senator, how you doing, Doctor? Good. All right, it's working now. Y'all can hear me well? Hey, so we got 1,000 things to talk about, but I know y'all are busy and want to give you plenty to look at. So I do have for you a set of slides talking about the status of COVID, talk a little bit about the vaccine, and we have some county-specific numbers for kind of look where your home counties are, both in the state, a number of cases and the per capita. So that's going to be for your perusal. So, Senator, are you ready for me to kick it off? Yes, all right. Yes, sir. I'm good, yeah.
I'm sorry, I can't hear a thing.
So if you look at page 1, you can see our case trends, and I think it's not too surprising that we're seeing pretty dramatic increases in the number of cases. It's going to be more than the summer for sure. We are heading in the wrong direction, and we've got a lot of negative headwinds to face. Right now, what we're seeing a lot of actually is we've done a pretty good job with schools up until about maybe 2 or 3 weeks ago, and we're starting to see a lot of cases of kids now catching it in school and bringing it back home. We've had a lot of outbreaks related to that very scenario, and I think if you have some sort of young adult folks who've caught it recently, ask them where they got it, and a lot of them we've seen are getting it from their school, and then a lot of it's from extracurricular activities. That's been something we've had a lot of trouble with. It's something we've tried to help try to get people to moderate, but most schools have not been willing to moderate extracurricular stuff, really to any degree, just to be quite honest. And then we're seeing outbreaks stemming from that into adults and then spreading out like in the workplace and that sort of thing. So we do have a different scenario now than we've seen thus far, and it's continuing to drive our case increases. If you look at the second page on the back, you can see the mortality burden. And you can see that it's starting to creep up, but we do expect for that to increase pretty substantially over the next several weeks. We always know that deaths are going to follow cases. If we talk about treatment, we have seen some improvement in in-hospital mortality with some new treatments, but still it's only going to be a decline from maybe like 15 to 16% mortality to maybe 11 to 12%. So we're still going to have a substantial mortality burden. And if you look at the number of people who've died in Mississippi, thus far in Mississippi, we've had 5,000 more deaths than we've expected. 5,000 people have died that would not have died because of COVID. And we're just, only about 6 or 7 months into this. And if we look at the number of people who've had it so far in Mississippi, about between 12 and 15% of people have probably had it in Mississippi. If everybody in the state of Mississippi got coronavirus, we would have an additional 30,000 deaths. It's just a simple math, and it's just simple reality of it. So anyway, expect more deaths going into the next few weeks. And if we look at our the second slide down here on our mortality by age, you can see that we clearly have more deaths as people get a little bit older. Younger folks do tend to do quite well with it. I mean, kids and teenagers do not die or have the same severity of illness, although we do have a significant number of deaths in young adults. But if you look at people over 65, of people over 65, 12% will die. Based on our historical numbers. And I was actually talking to one of my neighbors yesterday, and she was saying, well, she's just decided if she gets it, she's going to be fine. And I do hope she's correct. But she is around 70, and between 70 and 79, there's a 1 in 10 chance that she would die if she caught coronavirus. We've been kind of fortunate in the sense that most of the cases over the past few months have been in younger folks, if you look at the case distribution. But as it does start to filter into 50 plus, 60 plus, 70 plus, we are going to see some more severe illnesses. It's absolutely just inevitable. The other thing that's been sort of interesting to see I don't have these slides for you, is we've seen a transition from from a majority of African Americans, both per capita numbers and mortality shift, and now it's more Caucasian folks in both all mortality, number of cases, and the rate per 100,000 and the mortality for 100,000. So we have seen a pretty significant and dramatic shift on that. And then if you look on page 3, you can see our hospitalization, and this is one of the things that's really worrying us right now, and I know UMC just had a press conference talking about how extremely worried they are about the next few weeks. And you can see that we have this almost really sort of crazy increase in the number of new admissions. And we're seeing a modest increase in ICU, but again, it takes a little while. People get sick, they go in the hospital, they're there for a week or so, and then will end up getting sicker and then have to go to the ICU. We do expect that ICU utilization is going to increase over time as well. And if you look at the bottom slide here, you can see the number of hospitals that have 0 or limited ICU capacity. And then at the right, you can see the number of hospitals that are declining and saying they cannot accept new intensive care patients. So this is a real challenge that we're looking at going into the Thanksgiving. I'm going to just make a quick commentary before we go on to the vaccine conversation, because I just want to say we really, and I would encourage you, if you can, to message to your constituents how important it is going into the holidays to do a little simple things, keep smaller groups, try to keep young folks mingling with older folks, and if you are going to do something, do it small and do it outdoors. I was supposed to fly to D.C. this weekend to see my son who's in med school up there, and canceled it. It's just a bad idea. We don't need to do it, and we don't need to set that example. So it's something that we're taking seriously, personally, kind of practice what we preach. Without a doubt, most of the cases that we're going to see over the next few weeks, and most of the deaths, are entirely preventable with very simple stuff. All the things that we could do to prevent coronavirus could be done with 0 harm to the economy, right? But there's going to be some inconvenience. There would be people would not have to be able to go to soccer games, or maybe you'd cancel some tournaments, and maybe you'd have to wear a mask, and maybe you'd have to have a small group and not have big parties. But we have chosen very clearly to prioritize social events over disease transmission. And part of that's because we're tired of it, and there has been some effort to minimize the severity of the illness. Most people won't die, but a lot of people will die. And it's my job and our job in public health to try to prevent deaths and preserve health and prosperity. So anyway, just understand that we can do more if we're willing to. Moving on to the vaccine conversation, we'll move to the more optimistic side of the equation. We are very excited that we have now 3 potential vaccine candidates that are going to be available. If you see here on page 4, these are the 6 different vaccines that are part of the Operation Warp Speed sort of development process. And I'll go into a little bit of what these kind of vaccines are. And certainly if y'all ever want to have a conversation about this, I would be very happy to talk with you or town hall or whatever. The first 2, the Pfizer and the Moderna vaccines, are messenger RNA vaccines, and I'll talk about what that is. But the Pfizer vaccine they've already requested an EUA, and the FDA Advisory Committee will review that on December 10th, as we understand it. And then there'll be a couple other procedural things, but if things go quickly, mid or even late December, we should have an allocation of vaccine available for phase 1 recipients, and I'll talk about that in a second. And then in the next level, we have some viral vector vaccines. The AstraZeneca one looks like it's going to be pretty darn useful, and they're going to work toward EUA. We have every confidence, and we've got the other ones here. We do have several different vaccines under development for the United States, Operation Warp Speed, and I'll just go over it real quickly, but I wanted just to sort of raise some issues in case you want to ask questions. So the Moderna and the Pfizer vaccine are what we call messenger RNA vaccines. And if you think back to your biology class days, how does DNA work, right? DNA is your genetic code, but to affect itself and to do the things that your body needs to do, it translates itself in this thing called messenger RNA, and it's a single-stranded sort of copy of your DNA. And then it goes into the cell, and it translates itself into proteins that do the work, muscle proteins or hemoglobin or whatever. And so that's how it works. Well, what these messenger RNA vaccines are is basically these companies have taken the spike protein, which is the surface of the surface protein of the coronavirus, It's like these little spiky projections that stick out on the surface of the virus, the things that generate immunity if you get sick. And so they basically have created the genetic code for this protein, have encoded it into this messenger RNA format, and then they shoot it in your arm. So there's no virus in it. It's just the single-stranded copy of genetic information that your body absorbs, and your own body makes that protein. It makes this spike protein. And there's a lot of neat benefits to this because your own body makes it. It sort of mimics a natural infection but can't make you infected, and then your body will generate a robust both B cell and then this T cell immunity thing you've heard about. So it's basically a balanced immune response. And you can see sort of that like in that next slide. Very, very fascinating and exciting new technology. If we look at the next page on page 6, there are viral vector vaccines where basically they take benign sort of cold viruses and put that spike protein genetic material inside, and they give it to you, and then so that one produces the same spike protein, just a different mechanism of making it, and again, it will generate pretty good immunity. The last one we're going to talk about are these protein-based subunit vaccines. And these are the ones that are furthest back in development, so we probably won't see these till well into the future. And what these are, basically, it's the same as a flu vaccine. When you take a flu vaccine, are you taking the flu virus? No, you're not. What you're doing is they're growing up the flu virus in the eggs, and then they cleave off the surface protein, those little spiky projections. And so it's just that little protein, and they put it in a vaccine and give it to you. And so basically, if you want to compare it to the RNA vaccine, instead of letting your body produce it naturally, they just make it and give it to you to produce immunity. Now, there's some certain intrinsic things that are familiar about this and comfortable, but because it doesn't use your body's normal machinery, it doesn't generate as robust or as broad-based an immunity. So we'll see how this goes. It'll probably have some unique functionality, but would not be expected to have the same sort of 90% plus efficacy that we've seen so far. But we'll see. That would be hopeful, but information will be forthcoming. And then if we look at our distribution plan, we do anticipate probably mid-December or late December, we probably will have an early distribution of vaccines. And you can see from our vaccine distribution plans, it's going to come in several different phases. Our first phase, we anticipate about 90,000 doses that will be distributed primarily for frontline healthcare workers, first responders, pharmacists, National Guard, that sort of thing. And then phase 1B will be given it to long-term care folks, both residents and staff. And then once we get to phase 2, we'll be targeting broader population, but also hitting some higher risk sort of individuals. And phase 2 will probably be further into the winter, maybe even to the spring when we get the sort of volume of vaccines. But if we get more than one, if we get the Pfizer, and then we also get the Moderna, and then we also get the AstraZeneca, we're layering one upon the other, and that's going to be something that'll help us have better vaccine capacity going into the winter. And if you look at our distribution plan, how are we going to do this? Well, this is something we're spending a lot of effort on, but for the first phase 1A, we're going to use these primarily these closed points of dispensing. Basically, these are sort of emergency plans we work on all the time. Like if you had an anthrax or whatever, we have these sort of pre-planned sort of operations with major health systems and other folks, and we'll give them the vaccine and let them do it. Right, so like UMC, we have an allocation for them. We're going to have so many thousand doses. We just give it to them, and they have a plan to get it to their people. So we're going to distribute the planning and also the execution to our health partners. But additionally, we will plan to have Department of Health distribution sites probably through these drive-through clinics, like we have right now, and that'll be for other healthcare workers and first-line folks who would not have access through the other sorts of closed pods. Make sure everybody has access to it. And then as we get to 1B, if we look at the nursing homes, all the nursing homes in Mississippi have signed up to work with CVS and Walgreens to be their partners to give vaccine to them, and we'll also support other long-term care centers like assisted living and places like that may not be signed up for that initiative. And then once we get to 2B, we're going to be looking at more normal distribution chains that are going to be sort of augmented by our sort of drive-through capacity. I think that's really all that I had. We covered a whole lot of stuff. The only thing I didn't put in here is last week we did start distributing allocations, or we started working with hospitals to get this new antibody therapy, bamlanivimab. It's a monoclonal antibody that you give to folks who are outpatients only at high risk to prevent severity of illness and hospitalization. We just started that last week, and starting this week, we're going to try to get it out to outpatient clinics as well. So that's going to be something that's newly available. And then Regeneron, we've heard, now has an EUA to reduce, it's two different antibodies. It's the same one that the president got when he got sick, and that's going to be another tool that we hopefully have available in the near future to diminish hospitalizations, because we know we're going to see a lot of pressure on that going into the next few weeks. And that's everything I have, gentlemen.
Well, I may be the only one, but I'm having trouble hearing, so I'm not sure I've heard everything. Of all the things I thought about getting lined up, the fact that we would have this sound system, I just despair. How many things are there to dream up? If we could get the sound system we had 30 years ago, there were no problems with it. It was only since we started spending a small fortune on all these upgrades and fancy sound systems that we've had these problems. Looking at the slide, which is one of the last ones that's labeled Mississippi Vaccine Distribution Plan, Phase 2 says there are 2.7 million doses. Is that right? Am I missing something?
Well, phase 2 will be kind of a prolonged phase that will start with high-risk folks and then sort of bleed over in a general population. But yeah, eventually we hope to have enough vaccine for every single person in the state. But also you got to remember, most of them are 2 doses also. So each vaccine is going to be, except for maybe one of them, is going to be probably a 2-dose vaccine.
So when we talk about doses, it's my understanding that there are some vaccines which will require 2 doses.
Yes, sir.
And some vaccines will require 1 dose.
Mm-hmm. Yes, sir. But all the early ones, the Pfizer and the Moderna ones that we think are going to be the early release ones, those are going to be 2-dose series, one and then another one 3 to 4 weeks later.
Well, anyway, I'm still trying to figure out why it is that if we know so much more about the virus now than we did in March, that it looks like the virus is getting ready to spread far more rapidly than it ever has before. There's some disconnect there.
It's very much kind of like a water faucet and a mop analogy, right? We're getting better with the mops, but we have the faucet wide open. And until we turn the faucet off, we're really not going to be very effective. And the thing that's going to turn the faucet off, since we don't have the collective will to really, pull back in our behaviors, it's going to take the vaccine. I mean, I'll just confess to you guys, I'm exhausted trying to convince folks to do stuff. And it's just going nowhere. It's just going nowhere.
Well, if I understand what you're saying, it's that we know steps to take to reduce spread of the virus, but for whatever reason, the population is choosing not to take those steps. And so here we are.
Yes, sir.
Anyone else questions? Senator Blackwell?
Thank you, Dr. Drobbs. Mine's
yes,
working. Appreciate you coming and presenting to us today. I have several questions, and the chairman touched on one of them. There are, I think, 4 or 5 of these vaccines that require 2 doses, and who's going to do the follow-up on those?
Right. No, that's a great question. So for the close points of distribution or dispensing, the individual health centers will do it through their normal EMR process and that. But for our operations, we will obviously have a reminder process, but we're also, when we put it into our central, our distribution registry, it'll have an automatic reminder where we can actually do phone calls and that sort of thing, or text messages. So we will have a mechanism to do it. Now, for folks come in, that's part of it's going to be on them, but we do have a mechanism that is universally accessible to all healthcare folks who can see what vaccine they got and where. So if we gave it to them one day, there's an immunization registry that docs use all the time now and has millions of doses in their already, and they can go and they can see when they got it, and it'll actually forecast out when their next dose is due.
Right. So you kind of answer another question I had is, are you going to keep a record of those who aren't receive the immunization?
Yes, yes, sir.
So in essence, you'll be able to also tell who hasn't gotten the immunization.
We don't have a registry of non-participants, so we won't be able to go back and sort of say, so-and-so didn't get it. We can only say who did get it. And I will say also that, this is a registry we've had for a long time, and we used it for kids, and it's basically a medical record, right? It's like a health record. But we will not be sharing name-based data with the federal system.
All right. Of these vaccines, which one would you recommend?
I haven't seen enough about the AstraZeneca one, but I feel really good about both the Pfizer and the Moderna. And so if, assuming the information still looks good, and I'm confident in the process, and some of my colleagues and friends are actually on some of the advisory committees, especially the ACIP, which is the CDC one, that I know they're objective and they have, exceptional credentials. If they think it's good, and the Pfizer's out first, I'll probably be the first one in the state to get one, and to show confidence and get it myself.
Right. And my last question, on the number of deaths that we've had, there's a lot of anecdotal stories going around. Somebody has COVID, they get over it, get hit by a car, die, and the cause of death is COVID. So are these deaths that we have here in Mississippi actually from COVID?
Yeah, that's been an interesting tale. How we get COVID deaths is if the hospitals have somebody who dies of COVID, they tell us. And the other thing is if we get a death certificate that the coroner said the patient died of COVID, then we look at it, we pull the medical records and make sure it was from a COVID-related illness. So there's multiple levels. But if you look at our total number of deaths year over year, we have about 4,000 or so excess COVID deaths that we've counted. But if you look at the number of people who've died this year compared to the previous 3-year average, it's over 5,000 more. So they're tracking perfectly. We've had some of these weird sort of goofy things. If so-and-so had a motorcycle wreck and they got counted as COVID, and when we've heard these, we said, okay, send it to us and we'll look at it. And it's always been sort of a Facebook phantom sort of thing. It's kind of made the rounds. So, but if you hear about something weird like that, let us know. The other thing is, if someone gets coronavirus, they count one time, right? If you get tested 10 times, you count as one case. I know there's a lot of sort of weird theories out there, but if there's something that needs clarity, I'd love to answer y'all's questions so we can debunk some of these things.
Right. Thank you, Dr. Dobbs.
Yeah, thanks, sir.
Senator Wiggins.
Thank you, Mr. Chairman, Dr. Dobbs. Actually, Chairman Bryan kind of hit on the question I wanted to ask, so I'll ask it this way. And what your comments lead us to is it's a choice that the communities are not making to reduce the transmission. So my question is, I'll put it this way, why isn't it sinking in? Seems clear from what you have said, and medical professionals, that you wear a mask, you do this, and by the way, you're exhausted, thank you for what you do. In a lot of ways, my constituents are exhausted. I'm exhausted from hearing about it, to be quite honest. Why isn't it sinking in?
We don't have a consensus of communications. There's going to be a lot of debriefing on this after this is over. I think that if we could all be in lockstep, we've got a dichotomous approach. It's either lockdown or wide open. And the conversation is invariably in the wrong direction of, freedom and business, right, versus lockdown and oppression. And that's just a crazy dichotomy. All we have to do, just very sincerely, if we would all only have small gatherings, if we wouldn't do unstructured school stuff like choir and whatever, and in public or when they're all together, and if we would wear masks in public, or or just stay apart from one another and do it outdoors, we wouldn't be having this conversation. I didn't one time say close a business. I didn't say one time close a church or close a school. and we can't we just have not been able to vacillate toward that healthy middle of where, and that's one of the reasons why Sweden's doing better. They're doing worse than other Scandinavian countries, but they're staying away from each other. They're doing outdoor stuff. They're listening to the public health guidance, and it's a cultural thing too, because they do respect their government institutions and their public health folks. So, but I think whatever we can do to help one another, if y'all believe my message, if y'all can help share it with your constituents, but we have not had consistent messaging this whole time, and it's been it's been a voice in the wilderness, I'm afraid, and there have been some adherents, and a lot of people do listen. But right now, we've really switched our messaging to take care of yourself and take care of your family, because no one else is going to do it for you right now.
And, golly, thank you. So I think that, and for commentary purposes, I think that's important. I think that it's either this or that has been, when it first started, has been an issue. My observation anecdotally, and in my case, there's, schools have stopped things, but people are still, you can function in society without the either or situation as long as you do, it seems like, the things you're talking about. Would I be accurate in saying that?
Yeah, no, I think we'd be having a different conversation. We see over and over again parent-sponsored school parties that'll close the school down, right? Why is that acceptable? It drives me crazy all the time. I mean,
because
it's crazy.
from my observation is in my school, which I know I'm in Jackson County, but I actually think that where my children go, they've had really good experience. Yeah, they're going to have things, but for as many children as they have, it's been good. And the ones that they have infected are people coming from outside into the school, because the school has taken the precautions that they need to be taken. There's no choir, there's no band, there's no nothing. And yet it's the people who are doing that.
Yes, sir.
Is that what you're...
Yes, sir.
And last thing, all of what these recommendations, this is all based in science, is it not?
Yes, sir.
Okay, thank you.
Senator McMahon.
Dr. Dobbs, I want to begin by thanking you for your work. I know it's been a very difficult situation. In a lot of ways, it's a no-win situation for you in some ways. And I appreciate you always taking my phone calls, whether I've called in the early morning or late afternoon. You've always returned the phone calls. And for that, I'm grateful. Thank you. I wanted to go back to the markers. I wanted to go back to the vaccines. You said there were going to be 6 vaccines available. I get a lot of questions at home from constituents about these potential vaccines. Are any of these 6 vaccines going to have nanotech technology associated with them?
I'm not sure. They'll have sort of like microparticles, like the RNA vaccine will be in very small little components. So it'll be like, they're going to be smaller than a cell or smaller than a bacteria.
Is it biological or mechanical?
It's like an organic molecule. It's like a little fat particle almost.
What about any type of electronic or silica-based markers? Will there be anything like that in these vaccines, to your knowledge?
No, sir. No, sir. I know there's been some concern about that, and then sort of like on the fringe side about the whole Bill Gates sort of thing.
Sure.
That's not.
Well, I'm not in that camp, but I will say I get a lot of questions about it. So I wanted to try to be well informed to answer my constituents' questions about that.
Yes, sir.
So I appreciate that. Let's go back to the nursing homes for a moment. You briefly touched on nursing homes. We've continued to see the nursing home infection rates rise throughout this entire COVID event since March. But in many cases, I represent constituents that have not seen their loved ones since March of this year. And there is a growing pressure that people want access to their loved ones, especially in situations where the private citizens are paying out of their pocket to keep their loved ones in these nursing homes. These are not Medicaid or Medicare patients. These are people that have chosen to place their loved ones in a nursing home. And I want to know if you have any comments about that some of the nursing homes are not allowing access to their loved ones.
Yeah, that's been a real difficult part of this whole thing, and that's been tough because of the high mortality rate within the nursing homes. But I think through the summer, fortunately, we've seen a little bit of reasonable accommodation. For all the nursing homes, if they do take Medicare and Medicaid patients, they do have to follow the CMS, the federal guidance, right? So they have some pretty strict stuff, and we are sort of like the local hand of that piece. Now that being said, the federal folks have loosened things up so that any nursing home can do outdoor visitation at any time.
They may have that option, but many of them are choosing not to participate in those outdoor visits. That is a fact, Dr. Dobbs.
Yes,
and
sir.
I know you've had to help me crack open some of those doors to these facilities. And, you know, the nursing homes, if you're looking at just masking and wearing PPE as keeping the infection rate down, why have we seen our nursing homes continue to increase even though they've been locked down since March?
It's employees, without a doubt, folks coming in. And once it gets into the general population, there's no way to 100% keep it out of the nursing homes and long-term care settings. And that's one of the reasons why it's going to be so important to go and get the vaccines there, because and this is another thing I think that's really interesting to talk about, and I think it's important for everybody to realize, is we can't test our way out of this, right? Because these folks are getting tested every week, sometimes twice a week, and it's still not catching everybody. There's an outbreak that I was involved with recently that an employee tested negative and then was at a work assignment, and then the next day gave it to a whole bunch of people, and then was positive that next day. So the testing is not going to get us out of this, and it's not going to get us out of the nursing home thing. It helps. Everything's a tool, but we got to use all our tools together. And I think it's sad if they won't let their folks do outdoor visitation. I think it's really unfair for those folks. But also if a nursing home is not in outbreak status, they can have indoor visitation. But certainly it's understandable that if you're in outbreak status, they can't really have folks kind of coming in and out.
I want to be clear that, Dr. Dobbs, I appreciate how you've handled this situation, and I think that you've operated in the best, what's best for the public good. And please don't take this line of questioning, that I'm in any way being critical of you. It's just that I've had so many phone calls and emails about this particular situation, about the nursing homes in particular, that I had to take this opportunity to ask and ask you and put you on the record. And I hope you can appreciate that.
And I think when we've had conversation with nursing homes about outdoor visitation, they have sort of come around. I do think that there's a sort of an understanding from CMS that they should help accommodate the needs of their folks, and to some degree. And so if you have a specific location that's maybe not really meeting the needs of their clients, just let me know. We'll contact them.
And you've been helpful to me. There's been several nursing homes that I've contacted that were completely resistant to loved ones visiting their loved ones that they had not seen in 6 or 7 months. And your office has been very accommodating, has helped me make those phone calls and help people connect to their loved ones in those situations. I appreciate it. Thank you, Mr. Chairman, and
Senator
thank you.
Harkins.
Thank you, Senator.
Senator Harkins.
Thank you, Dr. Dobbs. To the vaccine distribution plan, y'all expect 1A to kick up in middle December. 1B would be how much further behind do you expect?
1A and 1B will kind of be almost simultaneous.
Simultaneous.
They should sort of go along the same route. In our total vaccine allocation, they've already sort of detracted from us the nursing home quantity, so it looks like that those will happen pretty much in lockstep.
All right, and then how far along do you think, realistically, 2B will be implemented?
1B or?
2B.
Oh, 2B? Spring.
I don't know what 2A was, but it's not on there, so.
Yeah, actually, I think I need to get the B off. I think it's just 2.
All right, well, we'll go with 2.
Yeah. Late winter, spring. I think a lot of it just depends on how many vaccines we have to choose from. Because obviously if we just have 2 or 3 versus 6, that's going to be a different sort of thing. So what we're being told is to get to general population, we're looking at the springtime. And then really have everybody vaccinated by the summertime. But this also doesn't include young children. The Moderna vaccine looks like it has been studied kids 12 and older, but all the other ones are 18 older. So there'll be a big slice of the population that would not be eligible.
Okay. Thank you.
Thanks,
Senator
sir.
Blackman.
Thank you, Mr. Chairman. How are you, Dr. Dobbs? Dr. Dobbs, what is the time frame for the emergency approval for FDA?
From submission to completion,
Yes, sir.
it looks like it's going to be about a month altogether, 3 weeks. So what's going to happen right now is, like the Pfizer folks, they've submitted their EUA request, and FDA is going to review all the elements and make sure they agree with the findings, and they'll do a sort of like a fine-tooth comb analysis. And then on the 10th, their advisory committee will review the data and then give them a thumbs up or thumbs down sort of assessment. And then from there, if it's looking promising, then it'll then go on to the ACIP, the Advisory Committee on Immunization Practice for CDC, and then they'll give it another review. So there's basically 3 levels of review before it would be sort of like in our hands to do something with it.
And I believe you said in another setting that the Mississippi Department of Health would review the findings as well before it's okay to be distributed in our state. Now, will you be doing that simultaneously, or will you wait until after they do all of their approvals and then you get it?
No, we will look at it as it comes through. So every bit of data that comes through now, we're looking at it. And so as the FDA puts theirs out, we'll look at all their findings, and also with the advisory committee and then ACIP. An ACIP meeting is an open meeting, and that's something that you can watch. But one of my close colleagues, who's the Arkansas State Health Officer, is one of the members of the advisory committee, and I talk to him every week about where things are. So we do have some good sort of connections to what's going on.
Thank you so much.
Yeah, thank you, ma'am.
We have time for one more question. I'm going to recognize Senator Parker.
Yes, sir.
My question has to do, I know with some vaccines like Shingrix and Zostavax and other ones like that, in general, if someone has had, for example, shingles, there's a 1-year waiting period before they are recommended to take that vaccine. Are you aware with any of these vaccines if someone who has tested positive and who has had COVID-19 will be immediately eligible to receive the vaccine, or should they be waiting? And then the follow-up question to that, of course, would be, if they should be waiting, how do we take account for the people who've been exposed and are unaware that they have been positive in the past?
Right. So that's a fantastic question, and we don't know yet. We're still waiting on the assessments from the FDA and ACIP to say what we think. Now, what we do think, though, based on a whole lot of other different lines of evidence, that if you've had it before and you're going to get the vaccine, it's just going to be like a booster, kind of like the flu shot, right? You get the flu, we give you a flu shot. So there's not going to be a pre-screening test to make sure you haven't had it before. So I think that part's pretty good. But if you have a documented infection, with a PCR nasal test or antigen, don't know what they're going to recommend about that just yet. We don't know what the data shows about those folks, and so that's an unknown until we get their final review.
Thank you.
No, thanks, sir.
Dr. Dobbs, we appreciate your coming. I know it's a busy time for you. I don't know if you've thought about this or not, but maybe if you, in your capacity as the state health officer, would just explain to the public the steps that they could take, maybe that would have a positive effect.
I'll keep trying.
Thank you.
Thanks, sir.
We appreciate
Thanks, y'all.
your time.
I appreciate y'all.
Our next presentation comes from Dr. Kim Hooper from the Hospital Association. Generally speaking, there has been a shortage of medical personnel throughout this experience. And of course, as we bid up the cost of medical personnel, that may help some, but the supply is relatively inelastic. And so one suggestion had been to consider nursing students who are not yet where they could become nurses, but to allow some of them under supervision of other nurses to get into hospitals with the thought that that would increase the supply of personnel and might alleviate the shortage. And so Dr. Hoover is here from the Hospital Association to give us an overview of how that's coming along. Thank you.
Thank you. I appreciate the opportunity to speak with you today. So I'm going to talk certainly about that student nurse model that was just being talked about, but I want to lay the stage first by talking about the hospital nursing workforce. The Hospital Association collects nursing workforce data every year, but since this meeting was going to occur before that data collection was over, I did a quick poll of the hospitals, the nursing leaders, just to see how dire the situation is. And in 3 days, I had 50 hospitals that responded to me, and that's a little under half of all of the acute care hospitals in the state of Mississippi. And just those hospitals alone reported that they had 950 RN vacancies, that's almost 1,000, 120 LPN vacancies, and 427 nursing assistant vacancies. And remember, that's just about 50 hospitals. So there are a number of factors that have affected the hospital workforce, but it's important to remember that hospitals really, before the pandemic, were already working on a thin margin. So that meant really working with fewer RNs than they might have been doing in the past. There are a number of things that we have to consider. So initially, some hospitals were hit so hard financially that they had to lay off workers, and that meant a lot of their RN staff as well. So when they were able to hire those staff back, some of the nurses had already gone on to work in other places. Some nurses, as you may have heard, really are not willing to, if they happen to be in a high-risk category, they really aren't willing to risk their health to work, and so consequently, if they think they may contract COVID, they're choosing not to risk their health to work. Nurses, like others, get quarantined. They are exposed in communities like others are, and when they're quarantined, typically that's quite some time, as you know, 10 to 14 days. When our nurses began caring for COVID patients, one of the things that was really obvious was that to be able to have nurses working in an area to make sure that the COVID patients were being cared for, but also they didn't go through their PPE, their personal protective equipment, as quickly as they would, they had to cohort these patients and consequently reduce their nurse-to-patient ratio. So for example, in a hospital, in a typical med-surg unit, you might have one nurse to 6 or 7 patients, and they had to cut that down to one nurse to 3 to 4 patients. And so that means really they had to have double the staff in some of the areas. And nurses, honestly, have not been able to take time off. I heard Dr. Dobbs talking about how exhausted he is, and I know many of your constituents who are working in hospitals are as well. They are working with limited help. They haven't had an opportunity to have vacations. They haven't had an opportunity to take personal leave, and honestly, they are exhausted, both physically and mentally. And I do believe that nurses feel obligated to their hospitals, they feel obligated to their communities, and certainly to their patients. But it is difficult when they see the public not adhering to simple protocols. And I've even had nurses who've told me that they have patients who are in positive for COVID, they are very ill, and families who don't believe that COVID actually exists. And so consequently, they're trying to deal with families in addition to dealing with the patients themselves. And finally, we are having nurses who are leaving the state to work for agencies that are hiring. So nurses are being offered as much as $5,000 a week to go somewhere else. They're being offered meals, per diem amounts for meals, and they're being offered housing. So basically, they're being offered what would be an annual salary of $260,000 a year with almost no expenses. And so the latest data last week showed that the greatest demand for travel nurses is in Texas, California, Michigan, Illinois, and Florida. So you can see we're right in between two states, Texas and Florida, where it's quite simple to simply get in your car and drive to those states to take a job that pays that much. Now, I was talking to about this to Tim Moore, and he said, you know, we know they're probably not going to get on a plane and fly off to Michigan and leave their families. And honestly, they're not leaving the SEC, but they will get in a car and go out to Texas, where they can go for a 13-week assignment, and then maybe they stay on for another 13-week assignment, or maybe they come home and stay. And to be honest with you, when the nurses come back, we have to hire them in the hospitals because we have such a shortage situation. So another issue that could certainly compound the problem was, just as you were saying, the inability to have students into hospitals because of the lack of staff for supervision and the need to preserve that personal protective equipment. So we need the nurses to graduate to fill those vacancies that we have right now and certainly those that are going to come. So we listened to hospitals and we also listened to schools of nursing, and they had two requests. The first of those was early on, the Board of Nursing granted temporary permits for nurses or students who had graduated from accredited.
Excuse me, I suppose I should interrupt. I have not been able to hear a plagued thing since we got this sound system. It never dawned on me I would come in here with this sound system. But there are other people telling me they can't hear. So I don't know what the solution is. I just report to you that people are reporting to me that they can't hear, and I will say it again, I haven't been able to hear anything since we got the sound system.
Well, I won't repeat myself, but is this better? Or about the same? So, get a little closer. All right, so I will, that's better. All right, I'll lean in just a little bit here. So I've talked about the issues that are facing the hospitals with the nurses, but the other issue that can compound that is the fact that nursing students were not allowed into hospitals, and for the right reasons. They didn't know what was going on. We really didn't have the staff at that time to supervise them because of the other issues. And we didn't have enough personal protective equipment for the students as well. And to be honest, many of the schools of nursing had donated their personal protective equipment to hospitals when this first happened, obviously not realizing that we were going to be going into this for so long. So we listened to the hospitals and we listened to schools of nursing. And what we found is they had two requests. In the beginning of the pandemic, the Board of Nursing issued temporary permits to students who graduated from accredited schools and said, before you take boards, we'll allow you to work, and then when you take boards, you can be hired by a hospital, you can work with your temporary permit until you sit for boards. What they were not able to do, though, is to issue that temporary permit if the person did not pass their boards. And so hospitals had requested that the graduate be allowed to have one more chance to still work in the hospital, just in a limited amount of time, and to have that temporary permit still be extended for them. So MHA agreed to actually look for funding to pay for a board review for these students while they were, or these graduates while they were attempting to take their second. And the other was they wanted students to be allowed to be hired by hospitals and to gain clinical credit while they were in the hospital. Now, the difference in that is that students typically have not had a flexible learning schedule. So they're in class all the time and they're in clinical all the time, Monday through Friday, and if you ask them to work on nights, they're going to be exhausted and not be able to pass their courses and certainly to get out of nursing school. But in this case, schools of nursing have had to go to either online learning or hybrid programs where the students are able to go home and learn on their own, and honestly, probably many of them stay up half the night anyway and study when they want and watch their lectures when they want. So in an attempt to get ahead of this before the fall surge, MHA convened a task force made up of representatives from the hospitals, representatives from the schools of nursing, from the Board of Nursing, and from IHL, the Director of Nursing Education, and you'll hear from Dr. McCrory in just a moment. So they recommended that both requests be allowed with guidelines for what we called the student nurse extender model. And so, for example, if a nurse is working by him or herself on a unit, and you have two senior nursing students who have been through at least one full year of school, it's not like one nurse working with two nursing assistants. You've got people who can go in and do things respiratory therapists can do. You've got someone who can go in and assist in a way a nursing assistant cannot do. And so consequently, you've extended that one nurse a lot further than he or she would normally be. So to make this work, though, students have to be able to have clinical credit for this. Now remember, there are accreditation guidelines out there that say for a student to have credit, he or she has to have work within some guidelines. They have to be able to have faculty oversight and to be overseen by someone in the hospital. So, in those two requests, the Board of Nursing's legal team reviewed our request about the temporary license. Since they didn't have the authority to actually grant that temporary license again, they're going to take that to their board on December 4th, next week, at their meeting and ask them to extend that license and to certainly to consider that. The IHL Office of Academic and Student Affairs received our request and our guidelines for the student nurse extender model, and they responded with recommendations that we pilot the student nurse extender model in the fall of 2021 and with 3 schools of nursing, and these 3 schools of nursing would be selected by IHL. Now, we also have had a summer extern program in Mississippi for a long time. Students work with preceptors, but they don't get any clinical experience for this. The IHL staff did suggest that we extend that program to the fall and spring terms, but again, clinical credit would not be considered for that. So because we don't have time to wait until the fall of 2021, we have encouraged the deans and directors and the hospitals in their own local areas to pursue partnerships to try to implement this model or some form of this model while remaining within those national and state accreditation guidelines. Remembering that every hospital is not going to hire students. Some of them already have students working for them. Some of them don't have the same needs. And they can't hire all of the students. They only need some students. And honestly, probably some students are not going to want to work. So it really was a work in progress to begin with. Now, the last point I want to mention before I take questions is that the hospital nursing workforce has been in a state of decline for several years. And I've been involved in the nursing workforce data collection and analysis for about 20 years now. The number of RNs who report working in hospitals has been, for as long as I have been involved in that, 60% or higher. So that's in the state of Mississippi, and that is nationally. So over time, we know that the financial health of the hospitals has really meant that it's become more and more difficult for hospitals to maintain many of these positions. I looked at the most recent data on the Board of Nursing Friday, and the percent of RNs who report working in hospitals is now at 42%. So that's a drop from 60% to 42%, and that's significant. Nurses are 24/7 in the hospital. The number of hospitals or beds in a hospital really, as you know, doesn't mean anything unless you have the staff, someone there to care for the patients. And as like Dr. Dobbs said last Friday, nurses are just not an expendable resource. So with that, I'll end my report and my update, and I'm happy to take questions from you.
Well, I can't hear and I can't understand. But again, my understanding is the heart of what we're trying to do is we're trying to get some nursing students who can work in some hospitals, and as I understand it, get paid and get credit for doing so. And that will increase the number of warm bodies in the hospitals providing care. Of course, it's not the same thing as having an RN, but it is someone with some training who can be, I think the term is, an extender for a RN.
Right.
And so at one point, there's somebody somewhere who has to issue a license, and sometime eventually some board's going to meet, and then they'll get around to approving this. And what board is that? Who is that now?
So the Board of Nursing is the one considering extending the temporary license, and that would ultimately impact about 200. Last year there were 219 students that were reported by the National Council that didn't pass boards, but that's 200 more who would be out working. The student nurse extender model is what we had proposed, and the AHL Office of Academic and Student Affairs was considering that.
So these are two different routes to get additional
Two different
person.
requests and two different routes.
And the temporary license involves someone who has completed nursing school but hasn't passed the exam.
We already have the temporary permit out there, so before you can sit for your exam, it has to be scheduled. When the pandemic hit, that got pushed out further and further because we didn't have places for them to go. So the temporary license was issued pretty quickly by the board, or temporary permit was issued pretty quickly by the Board of Nursing. We're asking them to extend it a short time if the person fails the first time, so they can continue working, have an opportunity to take a review course, and then sit for boards a second time, during which most graduates pass.
Well, just again, to try to see if I've got this straight, if you finish nursing school, you can get a temporary license between the time you finish your classwork until you take the exam.
That's
and
correct.
The proposal is to say that if you take your first exam and fail, that your license nevertheless would be extended to let you have a second try at the exam.
That's correct. The Board of Nursing's legal team has reviewed that, and they were comfortable taking that to the board next Friday to ask them to consider it.
Okay. So how long has this proposition been under consideration?
We started this work in August. The actual recommendations went forward in September, and I'm pretty sure, in just a second, it was the end of September, and then this has been under consideration now although we've gotten comments from both of them, for about 6 weeks now, although we started this work at the end of August.
It seems to me 6 weeks is an awful long time for somebody to consider something and sit around and wait and have a board meeting scheduled next Friday, or a week from Friday or whatever, but okay. So much for that proposition. Then, as I understand this other proposition for nursing students to go work and get credit, is it the case that everyone is agreeable to doing this? At least there are a group of people who are agreeable to doing it, but there is a problem with the nursing schools and their accreditation. Is that the stumbling block now?
So the schools of nursing do have to meet state and national accreditation standards. Those standards require a particular preceptor for clinical credit. So the number of nurses out there certainly make a difference. There would have to be some consideration of how one nurse might precept more than one or two students, and how faculty oversee those students. So faculty would be able to oversee them virtually. They would hold the same kinds of meetings with them and with the nurses in a virtual, either go-to meetings or Zooms. Those are not things that have been used. They're not typical methods that we've used. And so, yes, it is certainly a concern, and it's a concern for the schools of nursing that the last thing you want, you're not going to have anyone graduating from your program if you, of course, schools of nursing don't get their accreditation taken away immediately. They are put on probation and given citations and that sort of thing. But yes, it is a concern that unless there is support from everyone, some schools of nursing are going to be very hesitant to go into this. And so far, none have.
And as I understand it, every school of nursing in the state, regardless of its affiliation or lack thereof, every school of nursing in the state is accredited through IHL.
That's correct. And again, your next speaker, Dr. McCrory, will talk more about the.
Well, at this point, because this is all sort of mixed together, why don't we hear from Dr. McCrory about the concerns that the accrediting institutions have and where we might be with that. Dr. McCrory, do you mind just explaining to us in general terms, the concerns the accrediting operation would have with this?
Can you hear me? Okay. We did review the task force. As a matter of fact, I was a member of the task force, and we looked at several areas of that. Well, first of all, schools do have to be state accredited, but they're also required to be national accredited. So the outcome of our review did not negate participating. We just needed time to get some questions answered. For instance, schools that go into clinical facilities must have a legal clinical affiliation agreement, and schools do have those agreements. So therefore, it would be time to go through a process of adding another legal document through both their own institution and go through that process to get approval from their institution for the nurse extender model. The second concern is that when you look at clinical courses, there's a designated amount of clinical that's required per course. And so we again needed time to pilot it to see how much of the clinical time would the schools be willing to give up for students just to do repeat skills that they've already learned in a previous semester or a previous course, because we are educating students with new skills, and then the next semester they're stackable skills. So, and that's just an example of a few things. The other item that we needed time for was to correspond with the national nursing accrediting bodies to see what they would require if we propose to move forward with this. And yes, faculty do supervise students in the clinical area directly, and there are also schools that have a preceptor model where the student is paired with a preceptor at or above the level of the education that they are in the process of obtaining. For instance, an associate degree program, that would mean that the associate degree students could be paired with an associate degree preceptor. The baccalaureate students would be back to associate. Associate could be an associate degree nurse or a higher degree nurse. The baccalaureate nurse student would have to be paired with a baccalaureate or higher degree nurse for preceptorship. So we made our recommendations and offered to pilot it to work out all of the details. So all of the 23 schools, which is part of my presentation to you in a minute, all the 23 schools have time to be able to work through the details that we found or will find with the piloted program. Right now, as Dr. Hoover presented, there's a summer nurse externship program that has been in place for over 15 years. That's a summer program for students that have completed at least 2 semesters of nursing school. In the summer, it's an elective course that is connected to a 3-hour course credit. They don't get clinical credit because it's not a clinical course. However, the facility that hires the student, and every year there's about between 200 and 300 students that there's funds for through the local planning development agency. They get paid for like 300 plus hours for working in a facility, and they get a 3-hour credit, course credit, an elective course credit added to their transcript. So that was one of the recommendations that we came forward for immediately extending the summer nurse extern program to the fall and the spring. It's already in place. It's been working well for 15 plus years. It would provide the same relief to the nurses in the hospitals that you would get with the nurse extender model that's been proposed that gives clinical credit. It would be able to be immediately implemented with the addition of the institutions allowing another elective, 3-hour elective credit during the fall and the spring. So the models are similar. The one that's been in place, that's been working well, that policies and procedures have been worked out at our institutions through an elective course. It does require some faculty oversight, but not the kind of oversight that a clinical course would require. But at the end of the day, the summer nurse extern program would provide the same relief to the nursing staff at hospitals and would be easily implemented. But there are a lot of issues that we would need to work out for the nurse extender through the accreditation standards, and particularly national, and the legal documents that go along with the items that have to be reviewed both by institutions and IHL. So again, both models, one is already in place for the summer, the other is the proposed model, and they both would provide the same assistance to the facilities. The only issue would be funding for extending the summer nurse extern program to the fall and the spring. Where would that funding come from?
Well, maybe there's somebody on this committee that can follow all of this, but it ain't the chairman. This is sort of my dumbed-down view of things. We figured out certainly in March, if not sooner, that we had a pandemic which was going to put an extraordinary strain on our healthcare facilities. And fairly early in the deal, we figured out there was a shortage of medical personnel. And it's getting ready to be December. And I just don't understand all of this talk about summer programs and accreditations and supervisions and all. I mean, I understand the common sense of what we're trying to do, but I don't understand why it is just insurmountable to figure out a way to do this before next fall, when the urgency of the situation is going to be much less than it is this fall. Why is this such an insurmountable thing for those of you who know what's going on to figure out some way to act during a crisis? And as far as money's concerned, we've been sitting here with gazillions of dollars. Nobody's come to us and said they needed money for this that I know of. What? I mean, I've asked both of you here because I don't know who should respond to what, and I'm certainly not trying to, be difficult or or anything. I just don't understand why it is what seems to me such a straightforward concept is so difficult. And y'all work for the state auditor, by the way?
Well, the simple solution, sir, and the immediate solution would be to take the program, the summer nurse externship program that's been in place for 15 years, that is working well in the summer, it's an elective course, and extend it to the fall and the spring. It could happen this spring if there was funding from a source for the students that would go to work for the facilities in the spring. That is a simple, immediate solution to help with the shortage in the facilities.
Well, Dr. Hoover, I'm, of course, completely lost. Can you tell us what's wrong with this? I think you have to come up to this unworkable microphone for us to hear what you're saying.
So, first of all, the hospitals have said they will hire the student nurse. They will do what they can to get the student nurses in. But I just have to respectfully disagree that the extern model without clinical credit is the solution. While it does help the hospitals, students don't have unlimited time. They are still having to do all of their clinical and do all of their classwork, and then if they have a job on top of that, that's my issue, is we don't want to place a burden, and it just takes one problem and puts it on another set of beams, is just what I'm trying to say here. But the hospitals are ready to hire.
Mr. Chairman, may I ask a question?
Okay. I give up. But did I understand, Dr. McCoy, did you have a presentation that you wanted to make? Why don't we let you make your presentation, because I think I yanked you out of order, and we'll listen to what you have to say, and then we'll have questions when you finish, if that's okay.
Thank you. Thank you. You have a handout in front of you that's front and back. And it's regarding the anticipated nursing faculty shortage in our schools of nursing, which certainly compounds the issues that we're seeing now in our facilities. Yes, sir, front and back. Yes. On the front part is just some history I want to share with you that, regarding our schools of nursing. The regulatory authority for nursing education programs by statute in Mississippi is our Board of Trustees at the Institutions of Higher Learning. They are charged with annual program approval and accreditation of our current programs and new program approvals, and to administer student nurse scholarships or other programs of assistance that either exist or will exist through legislative enactment. We have 23 schools of nursing that registered nursing programs in the state that are regulated by the Board of Trustees, both public and private. And those schools offer over 40 degree programs. And you can see the breakout there. It's the associate degree programs, the number, the baccalaureate, the master's, and the doctoral programs. And this includes your public community colleges, your public universities that have nursing programs. 5 of those have nursing programs. And there are 3 private, 1 college and 2 universities. Each year, we present an annual report to the Board of Trustees from data that the schools of nursing upload to our secure site. This is just a snapshot. The report, the link to the report is on your handout. We have reports from 2005 through this most current one, and it has a lot of data about exam pass rates, certification rates for the nurse practitioner and the nurse anesthesia programs, et cetera, et cetera. So I'm just going to point out 3 areas that you might find very interesting. During 2018 and 19, which includes our latest report, there were 4,000 admissions across all of those 40 degree programs. There was a decrease in 5.4% over the past 5 years in the associate, baccalaureate, and master's program, and the highest decrease was in the master's program with 43% decrease. Enrollment in fall of 2019 was around 6,000, and there was a slight increase over 5 years, again, except in the Master of Science in Nursing program, where there was a 36% decrease. In 2018 and 19, all of the schools collectively graduated about 3,000 students, which was an increase of 6.5% over 5 years. However, the exception is the decrease in the Master of Science in Nursing at about 11%. And I'm going to speak to the next section, and you will see why I'm pointing out regarding the decrease in the Master of Science in Nursing. Faculty, to be qualified to teach in a school of nursing, a registered nursing program in the state, all faculty must have a graduate degree. If they teach in an undergraduate program, you can see the associate, the baccalaureate listed. They require a graduate degree in nursing, i.e., Master of Science in Nursing, or another high-level Doctor of Nursing Practice, and there's a lot of other ones, but let's just stick with the Master of Science in Nursing. Graduate programs, that has to do with your master's programs and your doctoral programs. That also requires a minimum of a graduate degree in nursing, but also it requires that they have a doctoral degree. Additionally, the Master of Science in Nursing and the doctoral degree programs, they educate nurses in specialty areas. They educate the nurse practitioner students, and most of you are familiar with the family nurse practitioners, which is the largest number, but there are other kinds of nurse practitioners. There is the geriatric nurse practitioner, there is the psych mental health nurse practitioner, there is a pediatric nurse practitioner, an acute care nurse practitioner. There's several types of nurse practitioners, and then you have your nurse anesthetist program, which we have one in the state, and that's at USM. So the faculty teaching in graduate programs not only have to meet degree requirements, they also have to meet those certifications themselves to be qualified to teach in those programs, according to state and national nursing accreditation. And the nurse anesthesia program has another level of accreditation, which is a national accrediting body for nurse anesthesia programs. So as I pointed out previously about the numbers of admissions, enrollments, and graduates, and the decrease we've seen in the Master of Science programs, this directly impacts these programs, both at an undergraduate and graduate. This fall, we did a survey with our schools of nursing regarding retirements. The survey result indicated that 23%, or around 144 nursing deans and directors, that's your nurse administrators that are running the programs, and the faculty are eligible to retire within 3 years. Our survey did not include resignations because you cannot project those. One accreditation standard that I wanted to mention to you, which there are others, limits the number of students for total enrollment, and that's per degree program. The associate degree, the baccalaureate degree, the master's degree, it's not a school of nursing total enrollment, it's by degree total enrollment. And certainly it's because, as you know, nursing and the acuity level of our patients we see, we do have to limit to be able to provide safe and quality care and education to our students and to the patients that they touch. So for example, with the 15-to-1 ratio, the student to faculty ratio, as an example of the outcome of the retirements that we collected from the survey, if you had 144 of the faculty retiring times 15 students, that if we weren't able to recruit and hire and retain those faculty, then that would be about 2,000 less of students enrolled in our schools of nursing. And going back up to enrollment, you know, I shared with you there was about 6,000 enrolled in fall of 2019, so you can minus 2,000 of those. So that's why we're very concerned about the upcoming anticipated and eligible retirements of our nursing faculty. We've had a robust loan scholarship program for many years. I would say for 15 years, just for sake of giving you a number, that covered the undergraduate student at the baccalaureate level and then the graduate students. The service obligation back to the state was for every 1 year of loan, they would provide service obligation in the state for 1 year. The teacher stipend that was a stackable for the graduate degrees, they would provide 2 years of service for every year of the stipend. And that was, again, a robust loan scholarship program in the state. It's been unfunded since 2016. State financial aid statute prioritized the undergraduate grant programs, the MTAG, the Eminent Scholar, and the HELP over all other financial aid programs. The highest year in 2014 and 15, when it was funded, we were able to make 609 awards to the students at all of those levels I just mentioned at a cost of about $2.3 million. The following year, and since then, we've not been able to receive funding. However, just to give you an example of the following year, we had 709 applicants, which would have been $2.5 million. However, since 2016, we've not been able to fund the Nurse Forgivable Loan Program. In 2018, NSPARC study of the state aid programs found that 91% of nursing graduates who received a graduate level forgivable loan completed their service obligation. And almost 95% of those remained employed in Mississippi 5 years later. So the return on investment for the Nursing Education Forgivable Loan Program and the teacher stipend in the past has been excellent. Now, if you'll look on the back of your handout, this is our, I want to speak a minute to the proposal to replace the anticipated or the eligible retirees, the faculty retirees. We would like to increase the number of nurses with graduate degrees available to teach in nursing programs by securing funding for graduate nursing education loan programs targeted for nurse educators. We already have a policy in place, as I mentioned previously, of our robust loan program. So the policy's already there. It's through the Mississippi Office of Student Financial Aid, and you have a link there if you want to read more about that. The Nurse Education Forgivable Loan Program Rules and Regulations. We're just, at this point, proposing graduate level loan programs. So the first one is the Master of Science in Nursing, and the abbreviations in parentheses is what the state financial aid program utilizes when they, on their website. But it is about the Master of Science in Nursing. It's, and this is what has been funded in the past, the same amount whenever we received funds. $10,000 over 2 years of full-time study with 1 year of service obligation for every year of the forgivable loan. The second one is the doctoral levels. You've got two types. We have a PhD program in our state, and we have a Doctor of Nursing Practice. Both of those are doctoral degrees. $12,000 over 2 years of full-time study for 1 year of service obligation for every year of forgivable loan. And also, there's a third nursing teacher stipend program that we've had in the past, and this is an optional one for students that apply for either the master's or the doctoral. They can also apply for the nursing teacher stipend program, and for each one of those degrees, at the master's level, it's $1,000 a month for 12 months. There's 2 years of service obligation for every year that they receive the stipend. For the 2 doctoral degrees, it's $1,000 a month for 24 months, 2 years of service obligation for every year. The service obligations for both the forgivable loans, the master's and the doctoral program, and the teacher stipend can be discharged or met concurrently. We looked back when during 2014, 15, and 16 to come up with the amount of funding. We used an average number. This is when the nursing loans were fully funded, and so we developed this budget for graduate nursing forgivable loan programs and teacher stipend. This request would require a 2-year funding commitment of a little over $2 million and would fund 146 graduate students. Now, our table breaks it down for you to see where the money would go. On the table, the NELM is, which in parentheses, the master's. Then your next one on the table has to do with, with your doctoral programs, and the last 2 have to do with the teacher stipends. So we broke that down by FY 2022 and 2023. I hope that you'll consider this funding request so that nurses have an incentive to teach in Mississippi schools of nursing, so we can continue to meet the demand for nurses in our hospitals and our other healthcare facilities in the state. And now I will be happy to take your questions or additional questions.
Well, just in general terms, we've got a water main burst and water's flowing out in the street and flooding the streets. And yes, long term, it is the case we need to do a better job of managing our water system and our pipes. But in the meantime, we've got to do something about this flood. And so I appreciate the information about what we have to do long term to have a reasonable supply of nurses available in the future for the state of Mississippi. But is there anything that either of you see that can do anything to get some more, that's actually going to happen, that can get some nurses or additional nursing students actually in the hospital providing some relief before the crisis is passed?
Well, sir, I do want to share with you that when the pandemic started in the spring, students were not allowed to go in hospitals and some other healthcare facilities. So during the spring, the students, at IHL, the accreditation standard normally allows students to use up to 25% simulation. So in order for students after March, when this all came about, to complete the semester and or some to graduate, we increased their ability to use simulation up to 50% for the rest of the semester because they were not being allowed in the facilities. I worked very closely with Dr. Hoover's staff in the office of the Center for Quality and Workforce to keep informed about when hospitals were going to allow our students in the summer and the fall. I'm pleased to let you know that our students this fall have been allowed in clinical facilities across the state. They have been allowed, and as a matter of fact, most of the universities and colleges have completed their semester early by Thanksgiving, and I'm pleased to inform you that our students are in hospitals, and they are supplementing through their clinical hours, assisting the nursing workers in the hospitals. Our students are in hospitals, and for the spring, I have contacted all of our schools of nursing to find out the status of their ability to be in the clinical facilities, and they have already assured me with their local facilities that they, at this point, do not have a problem with being allowed their normal clinical hours in a clinical facility.
Okay, do members of the committee have questions for either Dr. Hoover or Dr. McCory? Senator Blackwell.
Thank you, Mr. Chairman. Oh, did you?
No.
Thank you, Mr. Chairman. Just a few questions for you both, I guess. To sort of summarize, you're in this situation because when COVID hit, there are a lot of restrictions put on your program, and if I understand correctly, your nursing program is very structured, and you have a lot of you have to meet certain accreditation standards, not only here in the state but nationally as well. So when the hospitals, COVID hit and the hospitals shut you down, there goes your clinical rotations. Am I correct on that?
Yes, some of those can be met in other ways, but if you want to summarize it that way, yes, sir.
All right, and I think sort of to the chairman's point, he was kind of asking what can be done to get over those kind of hurdles. And I don't know what can be done if you're held to national standards as well, unless you've been meeting with folks on a national level. Have you?
We have not proposed the nurse extender model to our national accrediting bodies. There's 2 of them. That's why we needed time to field out what schools wanted to participate and filled out our questions about maintaining our national accreditation, because we're an education environment, and certainly students appreciate our healthcare facilities, but we have to be mindful of safety and quality of what our students are doing at the same time with assisting the facilities. So there is a balance there that we have to be able to assure.
Absolutely. On this summer externship program that you were talking about funding for it for the spring and fall. And it sounded like you said funding for the students, and they're going to be working, so they're going to be getting a salary. So what is the funding for?
In the summer, and I'll let Dr. Hoover speak to you more specifically where that money comes from, because it has nothing to do with IHL. It's a partnership with the Hospital Association, with the schools of nursing, to allow students to work 300 and something hours in a facility and get paid and receive a 3-hour, an elective credit at the institution. And there's about 200 to 300 students, and I think it comes from the local planning development agencies, but for it to be extended in the fall and the spring, I'm not sure where that money would come from. But the students still could get a credit hour elective if the money was there and still get paid to work. And I do want to interject that I make accreditation site visits to all of our schools of nursing. I've made over 40 accreditation visits in my 12 years at IHL, and I do spend time talking to students, and I don't know if you're aware of this, but students work. The majority of nursing students are already working jobs, various jobs, at least. A lot of them raise their hand at least 20 hours a week, and some are working full-time. So they also have personal jobs that they're doing to be able to take care of their families. I just wanted to let you know that when I was a nursing student, I didn't have to work. But the students now, we used to call them non-traditional. Our traditional students are working.
Right, I guess I was trying to, who gets the money when you're asking for funding?
So the externship program is a program that has been in place. Typically, hospitals just hire the students. And so they work and they work at the skill level that they're at in nursing school.
Right.
But there are some hospitals that couldn't afford to hire those students. And so we were able to get money from the workforce planning and development districts to help fund some of those hospitals that just didn't have the money and to fund extra positions. So we had more students going out because they often stayed with the program. The issue is that the summer externship program is there because students don't have classes. Only the students who don't have classes during that time are the ones who participate in that externship program. So consequently, they are able to get out there and get great experience and doing a lot of things, and honestly learning things about how to clinical decision-making skills, not just the I'm going to do something with my hands, but how to think about it and how to watch and listen to the other nurses. And honestly, it's it's like any of us going somewhere and staying somewhere for 2 months and learning a lot about it. And the truth is, right now, the schools of nursing are ending, just like other programs at the universities are ending early. What my hope is that because they're ending their classes early, that there will be at least a month that hospitals can hire them. It's not very long, but right now they're just looking for any relief that they can get. And then maybe we can have some for the spring, rather than simply doing the clinical, some of those students can actually be hired for other shifts.
Right. And you mentioned hospitals. Could clinical settings be I guess, a place where these students could go as well?
So students go to a lot of different clinical settings other than hospitals. It just happens to be that the hospitals are where the need is right now.
All right. And then my last question on the enrollment decreases in the MSN program. Is that, could you elaborate maybe on why or what you think there's been a decrease for? And I imagine are they primarily nurse practitioners going in that program?
No, sir. They're just a mixture. They're in the Master of Science in Nursing programs. There's role-specific areas that the master students are interested in. One would be nurse practitioners. There's nurse educators. There's nurse executives, your CNO of hospitals. They're different role-specific, so there's not one particular role. What we saw, and as you can see over the last 5 years, and particularly, we're not saying because we've not been funded since 2016, but I think that's a variable that our loan scholarship has not been funded, that individual registered nursing has chose not to go further their education. So we do know that that's one variable that could have impacted the decrease in the Master of Nursing. Now, your community colleges probably are more impacted with this than your universities, because a minimum of a master's degree in all of our schools are required. And so, we have 15 community colleges, and they have the majority of the nursing faculty across the state. So, we see this trend going. We did look at some other trends that might have impacted the Master of Science applicants. We did a survey of out-of-state programs, about 13 of them, to look at their admission criteria for coming into their programs and why our programs were losing potential applicants. And one was the GRE, the General Record Exam, that 11 of those 13 schools that we looked at, both public, private, for-profit, nonprofit, we looked at that, and most of them no longer require a GRE. So that was one component. Are our potential graduate students in the master's program going out of state because they did not want to meet, or they couldn't meet or take the GRE. So this spring, we did change our accreditation standard and deleted that as a requirement for our Master of Science in Nursing program. So we're hoping that's going to show some impact. We don't have data yet on that, but I hope I've answered your question.
Yes, ma'am. Would scope of practice limitations have any impact on a nurse choosing to go to get their master's here in this state or another state that doesn't have the limitations?
The scope of practice?
Right.
Are you talking about what they can do in our state
Yes,
versus
ma'am.
getting a degree from our state and getting a degree from another state?
That would allow them to practice more
No,
openly?
it makes no difference, because a Master of Science in Nursing, whatever their area, their role-specific area, like a nurse practitioner, they would be under the scope of practice for the Board of Nursing. A regular Master of Science in Nursing is under their scope of practice. It doesn't matter from what state. It's the state's law and the scope of practice through our Board of Nursing.
We have time for one more question. Senator McMahon.
Mr. Chairman, thank you. Dr. Hoover, I want to appreciate a comment you made. We're looking for ways to address the shortage of nurses, and you summed it up when you said, in a practical application, the schools are finishing a month early, so you're going to hire those students and let them work at their skill level. Thank you for presenting that, because that's what this entire committee meeting is about, is how we can fill the shortage. Dr. McCoy, I've got several questions. I'm just curious, how many years have you served on IHL, ma'am? I'm sorry I don't know that information. 12. Do you practice currently nursing or teach?
No, because my role does not allow me to teach in schools of nursing. It's a conflict of interest.
I know the answer to this, but for our guests here in the gallery today, who sets the state accreditation for certain graduate programs or for nursing?
The Board of Trustees of the Institutions of Higher Learning approve and accredit the state schools of nursing. However, our schools of nursing must be nationally accredited, and we have to adhere to their accreditation standards.
Even in a pandemic?
Yes, sir.
So there's no flexibility. If there's a medical pandemic, there's no flexibility for that accreditation, even though most of the federal regulations have been suspended for PPE manufacturers and for all types of different regulations have been suspended during the pandemic.
The accreditation standards that were issues in our School of Nursing that they brought up to us, we have addressed. Particularly, again, I mentioned simulation. We've allowed our schools to do up to 50% of their clinical hours in a clinical course for simulation until the hospital situation where the students were allowed back in this fall. Yes, sir, we do consider those and try to meet those, again, looking at safety and quality of the education for the students.
The Master of Science, the Master of Science in Nursing that you talked about here today, you did a beautiful job lobbying this committee for more money for that program, but I have a question. What does that program cost annually? So let's say that I qualified and wanted to go through the master's program, Masters of Science program in nursing. How much does that cost a year?
That would be an institutional question, sir.
What do you think it is? You pick the institution.
I am not qualified to answer that question. That's an institutional funding question.
You're on IHL as the Director of Nursing Education, and you don't know what the basic cost is or the average cost is for that program, even though you want us to put more money in it?
Every program in the state is different. Each institution has different degree programs, and they each cost differently based on the number of students they have, et cetera, sir. So I'm not qualified to answer that question.
What about, instead of us putting more money towards that program, have you made any recommendations to any of the institutions to cut their cost in half to attract more students that year?
Again, that's not in my purview.
What do you do on IHL as the Director of Nursing Education?
I monitor the activities of the schools of nursing, such as accreditation requirements related to the qualifications of the nurse administrators, which are the nursing leadership, faculty requirements, student requirements for admission, outcomes of the programs, such as completing the degrees, NCLEX exams, nurse practitioner exams. These are just to name a few. If schools of nursing have changes, that has to come through us for review before it goes to national accrediting bodies on either adding or taking away items that they are already doing or wish to do. That's just a quick overview, but it's direct nursing activities.
I think your answer is pretty thin, but thank you. Thank you, Mr. Chairman.
Thank you for coming. I appreciate y'all coming. The committee really doesn't understand. I think I can speak for the committee in saying we don't understand all the minutia, and it's really beyond us to understand it. But I think the committee is very interested in doing whatever we can in this crisis that we're in to get as much relief as we can, even though it may not be a perfect situation. But again, thank you both for coming, and I would encourage y'all to continue to visit with each other. Our next speaker is Bill Rosamond, who is the new coordinator of mental health accessibility. I would say that the legislation which established Mr. Rosamond's job was delayed in that the entire session was delayed. And as you know, we do an awful lot of work in the closing days of the session. And so for all of those reasons, the legislation itself was imperfect, and some of the issues that came about because of the crush at the end of the session. There were issues with the personnel board, and I've said before, and I'll say again, I am convinced our state personnel rules were made by a bunch of Talmudic scholars on LSD. I've given up. But ultimately, we were able to get a position authorized and Mr. Rosamond employed. And so I've asked him to come here today and just give us a very brief overview of how things are going so far and tell us a little bit about himself. And when he was growing up, did he think one day if I apply myself, I will get to be a mental health czar? Or exactly how he got here, and sort of a brief overview of where you see things headed. Mr. Rosamond.
Chairman Brown, Vice Chairman Parker, fellow committee members, thank you for the opportunity to appear before you today. As Chairman Brown said, I've been appointed by...
Can you please pull the microphone closer to you?
Is that better, Senator?
Little more.
A little more. How's that?
That's good. Thank you.
Thank you. I've been appointed by DFA Executive Director Liz Welch as the coordinator of mental health accessibility. Prior to this position, I served as a Special Assistant Attorney General for 10 years. I represented the Department of Mental Health for the last 5 and the Department of Human Services before that. I would like to talk with you today about the legislation the legislation that created the position, and give you some updates as to what has occurred since I began working in the position on November 1st. The stated goal of the legislation is to reform the mental health delivery system so that necessary services, supports, and operational structures for all citizens with mental illness and alcohol and drug dependence are accessible and preferably delivered in the communities in which those persons live. In reviewing the system, we'll be looking at community mental health services such as programs of assertive community treatment, crisis services. We'll also be looking at institutional services, which are largely accessed through the process of involuntary civil commitment. In addition, we'll be looking at core mental health services for adults, children's mental health services, services for those that are intellectually and developmentally disabled, and substance abuse prevention and treatment rehabilitation services. The legislation sets out certain powers and duties, which includes a comprehensive review of the state's mental health system to determine if all of those services is adequately provided in each county in Mississippi and each geographic area in those counties, especially to persons with serious mental illness. We will analyze and review the structure of the mental health system, the adequacy and quality of individualized services and supports for persons that have been discharged from the state hospitals and persons that are at risk of serious risk of institutionalization throughout the state. We'll provide quarterly financial statements and reports on the individual community mental health centers. The legislation authorizes my office to consult with the special master in the Olmstead litigation with the Department of Justice, the Department of Mental Health, and the community mental health centers, and other stakeholders in the state system. And again, we will determine whether mental health services are adequately provided in each county in the state, and determine whether community mental health centers have sufficient funds to provide those services. We will report quarterly to state leadership, to the Department of Mental Health and the regional commissions and other stakeholders regarding the status of the mental health system, and we will additionally report to peer quarterly regarding the financial condition of those regional community mental health centers. This legislation recognizes, I think, that the mental health system by its nature is a fragmented system between the Department of Mental Health, the institutions that it runs, and the community mental health centers, which it licenses and certifies. It's necessary that we make sure that community-based care is adequately provided so that we can reduce the reliance on our institutional system. In determining whether the services are adequately provided, the legislation sets out a procedure if a particular county has inadequate mental health services. If that is the case, my office would be required to advise the boards of supervisors that make up that regional commission that services are inadequate, and provide adequate time to them to develop a plan to remedy that service. If the service still cannot be adequately provided, we would look at adjacent counties and regional commissions to determine if they're willing to provide the service. If they are not able to do so, we would look at regional commissions statewide to determine if they are willing to provide the service. And if they were not able to do so, we would then ask the State Board of Mental Health to send out an RFP to public and private providers to see if they are able to provide the service in the region, in the county. On November 9th, we were informed, the State Board of Mental Health, that is, was informed that Region 13, Gulf Coast Mental Health Center, their boards of supervisors had passed a resolution to join Region 12, which is Pine Belt Health Resources in the Hattiesburg, Forest County area. That resolution was adopted by the Hancock, Harrison, and Stone County Boards of Supervisors to join Region 13, and the Boards of Supervisors that make up the Regional 12 Mental Health Commission also adopted resolutions on November 10th to allow those counties to join Region 12. This is a voluntary process that is contemplated by the legislation that you all passed, and my office is monitoring the transition of these services from Region 13 to Region 12. It is anticipated on February 1st of next year that Region 12 will be providing core mental health services in Hancock, Harrison, and Stone County. I am encouraged by these efforts toward consolidation. I think that is what the legislation intended, and we will continue to monitor that transition. Additionally, I'd like to update you on the Olmstead litigation with the Department of Justice. As you know, the Department of Justice filed suit against the state in August 2016, alleging that the state had violated Title II of the ADA, resulting in citizens being improperly unnecessarily institutionalized or placed at a risk of unnecessary institutionalization. On September 3rd, 2019, Judge Reeves entered an order finding the state in violation of Title II of the Americans with Disabilities Act. In that finding, Judge Reeves tasked the parties to work with the special master to craft a remedy to bring the state in compliance with Title II of the ADA. And in February of this year, Judge Reeves appointed a special master to work with the parties toward that goal. Most recently, on October 2nd, there was a status conference with Judge Reeves and the parties. The special master and the parties represented to the court that negotiations were coming along and would likely conclude at the end of the year. If the parties aren't able to agree to a remedial plan to bring the state into compliance according with the court's ruling, the special master would then submit a plan to the court in which Judge Reeves would then have an opportunity to adopt and bring the litigation to resolution, to a conclusion that is. So I'd welcome any questions at this time.
Senator Horn.
Thank you, Mr. Chairman. Mr. Roseman, so we're in a lawsuit with the U.S. Attorney's Office, or excuse me, Department of Justice, and we're in settlement talks. Would you agree? Are these settlement talks?
Not exactly, sir. The court did enter an order in September of last year. However, it was not a final order. I would characterize this more as a court order type of mediation, and if the matter cannot be mediated and settled between the parties at this point, the special master is ordered to submit findings to the judge as to what would bring the state into compliance with Title II of the ADA, and the judge would either at that time have an opportunity to adopt the special master's position in whole or in part and enter a final order at that point. At that time, the order could be appealed to the Fifth Circuit by either one of the parties.
Okay, but we're trying to put together a remedial plan right now, and we're moving slowly towards that effort. When do we have to have that remedial plan in place, or else the special master's alternative kicks in?
Well, the parties represented to the court that the negotiations towards the remedial plan would be complete by the end of the year or shortly thereafter.
Of this year?
Of this year. And at that time, if the parties signal they cannot agree and hold to a resolution, the special master would then craft his own plan based on his talks with the parties.
And do we have any expectation that we'll have that plan ready to be presented by the end of the year, which is about a month from now?
I think there are several key points in the negotiation that have yet to be resolved, and of course those negotiations are confidential to the public, but I think that it's questionable at this point to whether we can agree in whole or not. I think it's very questionable.
So there's every possibility that the special master's plan is one that the judge is going to move forward.
That's a very good possibility.
Mm-hmm. I've heard complaints from community-based mental health providers that their observation and judgment about how funding is handed out by the State Department of Mental Health and other funding sources is that even with the Department of Justice breathing down our necks, the rules and regulations on the funding favor the institutions of mental health provision as opposed to the community-based services. Have you heard anyone express anything like that?
Yes, sir, I have. If you look at institutional spending as compared to community-based spending across the country, the percentages in our state are much heavier toward the institutional side than other states. This past session, there was a $4 million appropriation for community-based services, and it's my understanding that there's a feeling that by the Department of Mental Health that $4 million will cover the things required in a proposed agreement outside of housing and supported employment. However, what you have to look at, though, is performance measures, and will that be effectively implemented with the money provided? We don't know what the performance measures that will be set in place by the court are yet. So I think that's where the question really is at.
So the $4 million is intended to address everything relative to community-based with the exception of housing and supportive jobs.
That's my understanding. It's intended to address things like PACT services, which is kind of like a mobile hospital, crisis services, peer services, those type things.
And in your work, have you experienced any upticks in mental health or mental illness amongst the homeless, say in the capital area?
I've not dealt with that subject specifically, but I think the two certainly go together.
Do you live in the Jackson area?
I do. I live in Ridgeland.
And as you drive around the metro area, have you noticed an increase in homelessness? And if so, are you aware that much of that homelessness is associated with mental illness?
I think that's fair to say that there's been an increase in homelessness, and I also believe that to at least in part be associated with mental illness. I certainly do.
So the $4 million increase is the only help that the state has provided financially in the way of this community-based mental health activity?
Well, the $4 million increase, along with other monies, $8 million previously also that was carved out of the department's budget voluntarily to assist with community-based services. That money, I think, will assist with treatment options, actual treatments for persons with mental illness in the community. With regard to housing, there's been $1.4 million roughly each year for the past 4 years appropriated to address the housing issue. My understanding is through that 4-year period that that has housed up to about 280 persons at any one point in the year. So
So do we have any estimate of how many people are out there who need to be serviced beyond the 280 some?
I don't have any estimate of that.
Thank you, Mr. Chairman.
Senator Wiggins?
Thank you, Mr. Chairman. Mr. Roseman, good luck to you in your new position.
Thank you.
I want, in various capacities, and let me back up. I'm bringing this up to bring it to your attention, and my question will be, if you've looked at it, and if y'all haven't, I'm asking for y'all or you to do that. And that is, in my different various capacities, a big portion of what I come across are family members of the mentally ill. And what I find is that they don't know how to cope with their family member who is mentally ill. They don't know where to go and take their family member to the places. They don't have the resources to direct it. And in cases that I've seen, they want to help, but they can't, or prohibited, or are somehow stopped from it. And if we're trying to put these folks back into the community, the hole, and I would call it a Grand Canyon that we're falling into, is that the families of these mental patients or mentally ill folks cannot either physically, emotionally, or whatever handle them. I don't know if that sounds familiar to you. And what I've found is that, so then what that leads to is they end up in jail, or they end up in you have to go through the chancery court system or something. And so my question is that what y'all are looking at? Are y'all looking at that? If you aren't, would you please? And third, are there things for the family members to be able to help their mentally ill patient, or I'm sorry, family members?
How I would answer that, currently there is a peer bridger program and peer support services program that is offered when a person is discharged from the state hospitals, and a peer is either a person that has had a mental illness or...
Well, I'm sorry, I know I'm interrupting you, but let me say, what I have seen is the problem is not, well, I mean, it's a problem, but the issues that I'm addressing are not dealing with the state hospital, because it's ones that don't even make it to the state hospital. It's the ones who writs are signed on at Chancery Court to pick them up, the family. I'll just tell you, I dealt with one last week in Greene County that the guy has a diagnosed mental illness, and the family signed a writ to take him in, and he was released back into the community. And they're like, what can we do? We have no way to do it. And they can't, they're at the end of their rope. And that has been repeated over and over again. I don't know where that is in the system, but it's not people going to the state hospital, it's people out in the community.
Senator Wiggins, I agree there needs to be an effort toward education in the community and in the court system as to how the process works and how to assist.
I would say that's extreme. Thank you for saying that, because it's like the family members don't know what's out there and they're not familiar with the system. If they were familiar, then they would know where to take their family member and go and how to treat them and all that stuff.
And I've had the opportunity to have this conversation with a number of chancery judges in our state. I don't think that there is, I don't think people are very well educated on the options that are out there. In order to comply with what's required under Title II of the ADA, in order to have a robust community mental health system, we have to have a citizenry, a court system that is aware of options in the community. And those options have got to function at capacity and fidelity in order to provide services that will divert people from the state hospitals. So we need to absolutely work on that. I think, as I was about to go into before you clarified your question, I think that there are things in place to educate on the back end of the commitment with regard to peer support services, but that's not so readily available when commitment and crisis happens at the outset of the crisis.
Yeah, so I think you're identifying what I'm getting at, and in my position as Judiciary A Chairman, I'm happy to help. So in whatever way we can to find something to address that. And if you've talked to the Chancery judges, it sounds like you're probably hearing what I'm saying from them, what they're seeing, what I'm seeing. And so if there's something we can do.
I'm going to interrupt at this point because we're running short on time.
I'm sorry, that was the last,
But
Mr. Chairman.
also, I'm going to interrupt to say that this exchange between Senator Wiggins and Mr. Rosamond gets at the heart of one of the most difficult problems in dealing with those who have mental issues. And one of the things, one way or another, we're going to make some progress on. And Senator Wiggins alluded to the fact that he's chairman of Judd A. Do you notice how he worked that?
In case you forgot.
But it ain't a legal problem. It's a healthcare problem. And where we have been historically is when people had mental illnesses that acted out, and were dangerous to themselves and to others, we defaulted to the legal system. And we still obviously need that as a backup in some cases. But we now are in a situation where we involve the Chancery Court in the process, because that's where you go to get some relief much earlier in the process and much more frequently than we should. But we have to have people who are trained to deal with those with mental issues. And B, we have to have actually functioning in the community the resources to deal with people who have these problems in order to fix things. It's a legal issue, it's a public health issue, it's a public safety issue, it's the whole ball of wax.
Mr.
And somehow, we're going to make some progress on that before we all get out of here at the end of this term. Yes, sir.
Thank you, Mr. Chairman, for saying that. And that's what our system gets overwhelmed because of this. And the point I was making that hopefully this new position can do is to help educate and train the family members so that it doesn't get to that system, which I think is what you're saying, so that they can take them to the right places and do that. Whether that, can be done.
And provide a place for them
And
to
provide-
take somebody to, because in lots of places, what do? You call the police, who else you going to call? And then you're automatically in the judicial. Do you have anything else before we?
Chairman Bryan, if I could just add to what Senator Wiggins was saying.
Sure.
There's got to be a quality service provided in the community-based system, and persons that need that service, family members of persons that need that service, and our court system has got to trust that service and be willing to give that service a chance as opposed to immediately resorting to institutionalization. So I think that's important too.
Yeah, and just to add, I think most court systems understand that. The problem is not having that resource in the community or whatever that they can send them to, or because they just let them back. But you know that.
Yes, sir.
I was about to wrap everything up, and Senator Horn looked over the most pitiful expression on his face. Even with the mask, I could say he does this, which brought to mind Senator Robertson saying day after day, they're this close, they're this close. So, Senator Horn, you're recognized for this.
Thank you, Mr. Chairman. Mr. Roseman, the other thing that I hear from community-based providers is that it takes forever to be certified by the State Department of Mental Health. Have you run across any activity that verifies that?
I have, Senator Horn, and the Department of Mental Health, of course, offers a certification to provide treatment and to be able to bill Medicaid for that treatment. I've heard that certification process can take up to 2 years to get certified for. If there was a way that services could be provided in the community and maybe supervised by somebody with that certification, that would speed the process a lot, and I think it would help with providing the service and also help the CMHC financially in order to build the service. So that certainly needs to be expedited, at least for billing purposes, if no other.
Thank you, Mr. Chairman.
Thank you, and thank you again, Mr. Roseman.
Thank you, Chairman
We
Brown.
appreciate it. We now have Bob Anderson, who's the Executive Director of the Department of Human Services. The name of this committee really is Public Health and Welfare, and we get so involved in public health, we haven't even gotten to welfare yet. But we're happy that Mr. Anderson is on the job, and I think he managed to get confirmed by the Senate, and so we've invited him here today to tell us how things are going so far.
Thank you, Mr. Chairman. I appreciate the invitation to be back with you. Mr. Blanton, our communications director, is passing out some folders that have basically the numbers that tell you a little bit about what we've been doing this year. There's a story behind every one of these numbers, as you well know, but I want to just walk through these real quickly in the interest of time. SNAP benefits, obviously at a time like this, when people are out of work, even today, I'm sure some of you have heard there's reporting about food insecurity in Mississippi. We're one of the most food insecure states in the nation. Well, we've been doing what we can at DHS to help with that. We have distributed more than $600 million in SNAP benefits this year. And between March and April, back when we were at the height of the pandemic, we were looking at applications around 68,000 in that 1 month period. We were processing about 24,000 of those a week. And employees were on the job working 12-hour days and 6-day weeks without any real questions, because they knew it was important that people needed to get food on their tables. And when the pandemic unemployment benefits ran out, we started seeing a spike again. Our numbers had gone down in July a little bit. They started coming back up in August and September and October, and we're back over 200,000 cases for SNAP as of the end of October. So until we get some more relief, if we get any more CARES Act type relief or pandemic unemployment type relief, we expect to see that SNAP number continue to go back up like it did earlier in the year. One of the other things we were asked to do this year that's really not in our wheelhouse, it's not something that DHS normally does, is something called pandemic EBT. And that is actually the free and reduced lunch program for students at schools who are eligible for free and reduced lunches. We were asked, that program is funded through the Department of Agriculture, but it is normally administered through the schools. Well, the schools were out, as you know, from about mid-March to the end of the school year. And so there were students that were entitled to their free lunch benefit from mid-March to the end of May, and we were asked by FNS, and we agreed to take on that task. We were approved to do it in June. What we didn't realize was that there were 375,000 eligible children, and we had a little bit of a hitch in the get along in the sense that the data set that we got from the Department of Education is created in October every year, and it's not updated after October. So here we were in June and July and August trying to match these benefits with the children to whom they belonged, and we wound up having to spend a lot more time at it. We ran into a problem even with our vendor preparing the cards, so I instructed our staff, let's take it in-house, we'll create the cards. We were able to administer the initial part of this to 184,000 SNAP recipients by just simply loading those school lunch benefits onto their SNAP cards. But that left us about another 200,000 that we had to get out the door. And so we had to actually create the physical cards, post the envelopes, and we were mailing out somewhere in the range of 7,000 envelopes a week. Because the data set was not as accurate as we would have hoped, a lot of those kept coming back, and our folks kept working through them and trying to get them back out to the families who were deserving of those benefits. If you're wondering how much each child was eligible for the month and a half that school was not in session, each child was entitled to $267.90 for the free and reduced school lunch program, and we did our dead level best to get every one of those students the benefits they were entitled to. The last numbers I have from David Barton, our Deputy Executive Director who handles economic programs, economic assistance programs, is that we have about 2,000 names that we can't match with the proper addresses, but we're working that last 2,000 cards trying to get those benefits to those families. And I can tell you that Mr. Blanton, our communications director, had more traffic about pandemic EBT, both to the agency and to social media outlets throughout the whole summer than we did on anything else. But we're endeavoring to make sure every family gets and every child gets the benefits that they are entitled to. And one of the other programs that we raised up during the pandemic that I am very proud of is called the Child Care Crisis Assistance in Isolation Response Plan, which is a mouthful. We refer to it as C-Care over at DHS, and it is a special program designed essentially to keep child care available for first responders and healthcare professionals and others who obviously during a pandemic, Mr. Chairman, can't afford not to be at work, and they have to have child care available. So what we did was we created some emergency procedures in order to certify some child care centers, because we had about 900 across the state who had shut down during the pandemic. We have about 2,500 who provide that child care benefit to families across the country, across the state, and so 900 of those, almost a third of them, were not operating. We were awarded some CARES Act money as well, about $47 million. This was directly from the federal government, not part of the separate money that the legislature appropriated, And we have used that for one-time cash assistance to these child care providers. We've used it to provide emergency certificates to families. We were paying child care providers based on their enrollment and not their attendance, simply so that we could keep them in operation. If we had paid them on their attendance, some of them would have gotten nothing during the height of the pandemic. And the ones that were willing to stay open and take whatever children were still coming, were still using their services, we paid them based on their enrollment. And we're in the process of pushing out about $3.8 million in PPE equipment to those child care providers out of that CARES Act, the money that we were appropriated. One of the things the governor asked me to do when he asked me to become executive director was to put the house in order at MDHS. And I don't have to remind any of you why the house needed to be put in order. It was in a mess. Or as the governor said, it was on fire when I got there. We began something I've been calling Operation Restore Trust. And we're focused on, and I've talked with you some about this, I think, back in June. We're focused on integrity, compliance, and moving the agency toward excellence. We've got a long way to go, but we've made some real strides. We created, as I told you back in June, an Office of Compliance, and that office has been the busiest part of the agency over the last 6 months since our first compliance officer came on board May 1st. She's been basically doing a shakedown review of every single program in the agency, whether they have standard operating procedures, and some of them did not, and having them put in place standard operating procedures and making sure that all of the standard operating procedures are in compliance with both our state and our federal statutory oversight requirements. This will allow the agency as a whole to move forward in a fully compliant manner, which is not, as I'm sure you would agree, the history up until about 9 months ago. We're trying to make the agency fully compliant, act with integrity, and move toward excellence. One of the other commitments that I made to the governor was we were going to do a forensic audit. We were going to look at all of this TANF spending. The state auditor's single audit questioned $94 million in spending. Well, you have question cost on one hand and unallowable costs. Those are not the same figures. Question costs are the auditor says, we're not sure there's enough information here for us to agree that these numbers, these funds should have been expended. Unallowable costs are, we look down at the guidelines, we look at the federal regulations, and we see those funds were never properly expended. And those are not the same numbers, but we have a forensic audit firm, Clifton Larson Allen, well-respected national firm. They are auditing every TANF transaction from January 2016 to December 31st, 2019. And you wonder what that coincides with. That essentially coincides with the time that former Executive Director John Davis was Executive Director through the end of calendar year 2019. We believe they're going to be looking at somewhere in the neighborhood of 100 to 125,000 transactions. We just provided the forensic audit firm a first upload, I'll call it, of data, bunch of documents, obviously thousands upon thousands of documents. And we will be getting periodic reports from the forensic audit firm once a month. We'll get our first report from them next Friday, December the 4th, and just continue to hear from them what they're seeing in looking at these TANF expenditures. We do not anticipate the audit spreading out beyond TANF, but what we have said in the scope of work is if in reviewing TANF spending or misspending as the case may be, they determine that there's some other programs where it appears that there's been improper spending, then they can come to us and request to expand the audit into that area. But right now, we're focusing primarily on TANF spending. And as I say, we are prepared to let the chips fall where they may. Whether that unallowed cost, I hope it's not 94 million. My real sense is it may be as much as a third of that number, but a lot of the work that was performed by some of those sub-grantees, even the ones who were troublesome, even the ones who were misspending money, there was genuine service being delivered by the lower tier subcontractors who were working with the problematic sub-grantees. And that work, I think, will ultimately be determined to be properly funded by TANF. But when we're talking about the allegations that you've heard about buying stock in drug companies and things like that, none of us can justify spending TANF money on those kinds of things, and those will remain unallowable, and the jury will decide whether they're illegal costs ultimately. This agency created an Office of Inspector General back in late 2017. In fact, it was out of the Office of Inspector General that the report to the governor was made that led ultimately to the removal of John Davis and the indictments that are out there right now. They have an investigative and an audit function, and in terms of actual fraud, they have recovered about $80,000 in fraud. That other number you see there, 4.8 million, that's what I would call overpayment recoupments, where people didn't report their income or their household numbers, those sorts of things, properly to the agency, and they were overpaid in SNAP benefits or TANF benefits, and we recouped from them that overpayment. Now, the last thing I want to talk with you about is what we're doing with TANF. We are still doing subgrants. And we did an RFP in July, and we had 46 applicants. But one of the things we have done is we have implemented a more robust, I'll say more robust. We didn't have a real selection process in the past. It was if you had a relationship with someone at the agency, the likelihood was that you could get a TANF subgrant. Well, we have a genuine request for proposal process in place now, and we have put a scoring system in place where not only are we taking RFPs, proposals for those RFPs, we're requiring potential subgrantees to score 75 points out of 100 in order to get a subgrant from MDHS. And what happened in July was, out of 46 proposals, our selection committee whittled that down, and they found only 9 that had presented an appropriate budget, that had presented a compelling narrative about what they were going to do, and that had the experience to be trusted with a subgrant. That's not to say that the other 37 may not do business with MDHS at some point. If they write a better proposal in an RFP that we have out right now, then they may get a subgrant. But in July, only 9 of the 46 were awarded a subgrant. We just released because we didn't award very much money, we had about $30 million available that we had set aside to award subgrants. So we released another RFP on November the 2nd, and that has just passed the first stage, which is the letter of intent phase, where those who are interested they send us a letter and say, hey, we want to be a part of this RFP. We have 43 letters of intent from other potential subgrantees, and that process will continue. We'll do the same evaluation and grading and award whatever number the selection committee determines from among those 43 meet the 75 points or more threshold. I want to be clear about one thing in particular about that. As executive director, I have no involvement whatsoever in that RFP process. And I think that's a good thing. The process works through our procurement office, and the Chief Procurement Officer, Brian Wardlaw, selects the evaluation committee. And in July, some of those folks were from outside the agency, from the Department of Education and some other agencies. That is true, I believe, also for the evaluation committee that will review this current RFP. And we have agreed to just simply take the evaluations. We're doing extensive training, more or less, with the evaluation committee to explain to them what does a model subgrantee for MDHS look like. And the areas we're looking for partners right now is in after-school programs and the parenting initiative. And I'm missing another one. Can somebody remind me what the third one is?
Workforce development.
So those are the three areas that we're looking for subgrantees. And essentially, what does a model partner look like? It looks like somebody who can do the work that if MDHS was out there in the community doing it, we would be doing it the same way. We're looking for somebody who can be a symbiotic and supportive partner with MDHS, somebody who has the expertise, who has the experience, and who has the staffing, and who can write a proposal that convinces us about that. Now, I realize we weren't giving much technical assistance as an agency to subgrantees in the past, so we offered subgrant training back in October for those who were awarded subgrants in the July RFP, and we are offering that training once again. We offered it again for those who are going to be a part of this November RFP. The other thing I thought we needed to do as an agency was teach our potential partners how to write a grant, because some of them, although they're doing great work in the community, if they don't have experience in grant writing, they really don't know what's important, what's not important. Is the budget more important? Is our experience more important? Is our expertise, our staff, what's more important? So we put together a sub-grant training piece and offered it for the first time October 29th. And we posted it, we offered it virtually, and then about 20 people came into our offices and had it on site. Then we posted that training on our website, and it was made available again November the 5th, and November the 12th, and November the 19th. And we're committed to continuing to do this grant writing training as well as the sub-grant training so that we can develop model partners to do these supportive services with us. And that is essentially what we have been up to this year. I want to mention a couple of things. Mr. Chairman, I will have for you, and I apologize, I do not have copies for all of the other members of the committee. I've been trying to get hold of these binders to put these together. I have a couple of them. I have one for you and one for our House Committee Chair. This is our legislative agenda. And I want to mention to this committee one particular item, and this has been vetted with the governor, and he's given me the green light, so to speak, to go ahead and talk with you about it. We're going to be asking this committee to entertain, for the first time in 21 years, an increase in the monthly TANF benefit amount. And the amount that we're going to ask you to increase the monthly TANF benefit amount is $90. That would bring our monthly support for a family of 3 from $170 a month, which is the lowest in the country right now, to $260 a month. Now, that will not cost the state a single state dollar. All we're doing is we're taking out of our $86.5 million federal block grant for TANF money, and we were redirecting some of that to direct assistance to families. Why are we doing that? Well, I heard said earlier, we want to put money back in the hands of families so that they can make the decisions about the needs of their families. That's exactly our rationale here. If we put more money, my theory is, if we put more money into the hands of families that are in crisis early on, the likelihood that they can get out of crisis is better and can happen sooner. So that's one of the primary legislative items we'll be asking this committee to support us in increasing our TANF benefit amount for the first time since 1999. With that said, Mr. Chairman, in the interest of time, I will take questions from any of the senators.
Just quickly, there are a number of programs that you mentioned in connection with the pandemic. How many of those did your agency have discretion about and were sort of generated or initiated by y'all, and how many of them were prescriptive and were things that you were more or less required to do?
If I understand your question, Mr. Chairman, we didn't have much discretion about most of them, except in regard to how we administered them. Now, we did have to ask USDA for supplemental SNAP benefits. For example, what we have done is we have raised families to the maximum level of SNAP benefits. We had to ask the Food and Nutrition Service at USDA to allow us to do that. Dozens of states did the same thing, and we exercised that discretion to request to push our SNAP benefits up to the highest level we could. We asked for some other waiver flexibilities. For example, we asked to be able to suspend some of our certification and recertification requirements during the pandemic. We normally would have to have face-to-face interviews, and we asked and we were allowed to do telephonic interviews with applicants. And in order to be able to do that, we had to put in the hands of our eligibility workers about 400 or 500 telephones so they wouldn't have to use their own cell phones and cell service in order to be on the phone with applicants reviewing their applications for TANF benefits. We asked for some waiver authority in the child care arena, particularly for this emergency type certificate, and we got some flexibility there. This C-Care program was totally designed by our Division of Early Childhood Care and Development. They came up with it. From what I understand, half dozen states are looking at doing something similar. So I'm really proud that we took the lead there. We also, I didn't mention LIHEAP, we have low-income housing energy assistance. We were given $9.2 million in CARES Act money, and that's primarily for home energy bills and weatherization. We also were given a separate $15 million for rental and mortgage assistance, separate from the CARES Act money that the legislature appropriated for landlords that's being administered through the department, the Mississippi Development Authority. And we are out there trying to identify eligible renters who can benefit from that $15 million in rental and mortgage assistance. I think probably one of the most frustrating things that we ran into during this pandemic, Mr. Chairman, is when every state asked for some flexibility. You know, we got the pandemic unemployment benefits where people were getting an extra $600 a month in unemployment assistance. Well, that $600, if it was counted against a SNAP recipient's household income, it would disqualify almost every one of them from receiving SNAP benefits. And we went to USDA and we said, give us a waiver so that we don't have to count that pandemic unemployment benefit, and they wouldn't allow us to do that. So one of the most frustrating things we had to deal with is, on the one hand, people were getting $600 a month extra, and maybe they didn't need SNAP benefits as much, but we were qualifying people at the beginning of the month for SNAP benefits, and then when they got their additional unemployment assistance, at the end of the month, we would have to disqualify them. And it created a significant amount of extra administrative work for us as an agency, because we were having to vigilantly say, well, you have $600 extra income, you're no longer eligible. And we just couldn't get USDA Food and Nutrition Service to give us a waiver in that regard.
Thank you. It sounds like you've been busy. We have time just for a couple of questions. Senator Parker wanted to ask a question.
Thank you, Mr. Chairman. I'm not sure if this is one that's going to be in your wheelhouse easily here, but what work do you do with the food bank on a regular basis?
Yes, sir. We do a lot of work with them. In fact, we just finished an in-house food drive. We collected about 3,500 shelf-stable food items. Most of that food bank work that we do, we have a division of aging and Division of Adults and Aging Services, and pre-pandemic, we did congregate meals for senior citizens. During the pandemic, we have been preparing food boxes and delivering those to the homes of our senior citizens.
One of the concerns that's been expressed to me is how it's delivered and where it kind of goes. So my understanding of this, and again, I'm a novice on this, is that a good portion of this is distributed out of Jackson, but for people in the coast area, for food bank services, most of that comes through Mobile, and for the northern part of the state, most of it comes through Memphis. And some frustration that I've heard, at least along possibly the coast and the northern part, is that when supplies are short or when funds are short, there seems to be an inability for those supplies to reach the extreme parts of the state, because it seems like the distribution is more centered through just the Jackson area, which has great need, by the way. But is there a need for us to put more money into the food bank so that we can shore up the coast and the northern part of the state, or am I missing something in this?
Is there a need for more money? Yes. I mean, the short answer to that is any additional assistance that is offered for food delivery, we can any extra capacity we're given, we can push that food out to families. We work with the Mississippi Food Network. They're our primary partner in that regard, but I'm drawing a blank about the name of the partner we have on the coast. We have a separate partner on the coast and then one out of Memphis. I'll tell you one of the things I've learned. I'm in this thing called the Business Advantage Program over at Millsaps College right now, and we had a session about supply chain management. Our supply chain for getting food out and into the hands of those who need it is not in the greatest of shape. We're doing the best we can, but we could probably use some more local partners, I guess, to beef up that supply chain so we could get that out more readily. And yes, the largest percentage of our folks are in central Mississippi, but there's plenty of hunger in North Mississippi and in the Delta, and even in places like Jackson and Harrison and Hancock County. Absolutely.
Well, I know that last year there was legislation introduced on the Senate side by Robert Jackson that had a pretty broad amount of support. I've been looking at that a little bit out of session, and it's my hope and my intent to get some action moving in this in a bipartisan method this year to fill some of these needs that are definitely out there. So I would love the opportunity to sit down and talk with you and your staff. The message that was relayed to me, and this could have been before your swearing in, was that there had been a lack of interest from DHS and speaking to people from the food bank about that issue, and that it was certainly a problem. I've had that discussion with other legislators, but I would love to see, not only for that, but also for the workforce development issue that you've touched on. I'd like us to come into this session with an idea to address this and have a plan on it before we get here.
Yes, sir. I will say this, there may have been, and you're probably accurate in saying there was a lack of interest in the past, but there are people in this room right now who've actually been to the food bank filling up boxes, and David Barton, my principal deputy executive director, who runs our economic assistance program, absolutely is committed to working with food insecurity and getting as much food out there. Beyond the SNAP program, getting food out to hungry families. And I'll mention one other legislative item that's in our agenda. It's really not even our bill. The Jackson Medical Mall Foundation and the American Heart Association came to us and asked if we would co-sponsor with them something called the Healthy Food Initiatives Program. And they're just simply asking, they'll be asking the legislature to fund a $700,000 program that is known across the state as the Double Up Food Bucks program, where if families who are on SNAP spend $1 on vegetables or fruits, they earn $1. Every dollar they spend, they earn $1, and they earn it in the form of a coupon at a farmer's market or a small grocery store. When they come in and they buy fresh fruits and vegetables so they can eat healthy food, they earn another $1 and then come back and spend that extra $1 every time they come back.
I think I'm going to be a co-sponsor of that legislation. I know a number of members of this committee have already been approached about that as well. So that is a good program. But, you know, again, I would just love the opportunity to meet with you or your staff. I guess most of them are in the back there. You know, sometime ahead of time, particularly on the food bank issue, because I want to gain more information on it and have a solution if we can find one for that issue.
Senator, let me introduce, by the way, this is Rochelle Richardson. She's one of our deputy executive directors. She actually has the Division of Aging and Adult Services under her purview. And then we have a new legislative liaison. He's not even on the payroll yet, but he came over today. This is Daniel Galarno. He'll be starting with us on Tuesday as our new legislative liaison. And then I mentioned Danny Blanton. He's our communication director. So,
I'm going to recognize Senator Blackman for our final question.
Thank you, Mr. Chairman. Mr. Anderson, of that $9,200,678 for the low-income home energy assistance program, how much has been expended?
Not very much. I think about the last time I checked with Tina Ruffin, who is our director of our community services division, we pushed that money through, as you know, to the community action agencies, and I believe they have on hand still about $8.4 million of that. So there's a lot of capacity still there, and we've done our best to try to get the publicity out there and let families know, come and apply, and we have to make an eligibility determination, but once you come and apply, and if you're eligible, the money's there.
It will expire 12/31?
No, ma'am, this money will not. Actually, this money, this is not subject to the December 31st deadline. We have until, I believe, don't hold me to this. I know we have at least till September 30th of 2021, and it may be that we have 2 years, but we have at least through the end of the next fiscal year, September 30th, 2021.
And that $15 million for rent mortgage assistance, how much of that has been expended?
I have not gotten an update from our community services division about that. I don't think very much of it has. I think about $500,000 maybe.
And it will go through 2021 as well?
It's on the same grant, as I understand.
Thank you very much.
Yes, ma'am.
Mr. Anderson, looks like you've been busy. Thank you for coming. Before you leave, I just want to make mention of one thing. You mentioned the employees you had that were working 12-hour days processing SNAP applications. I would say, from my perspective, they're representative of an awful lot of state employees and an awful lot of agencies who believe in the mission of their agencies and do work hard and do show up and work when the time comes that something has to be done because they believe in what they're doing. And I know there are some worthless state employees because we've got tens of thousands of them. And some of them have got to be worthless. You know, we've got worthless legislators and worthless lawyers and worthless Baptist preachers. I mean, we don't have perfect humans. But I would say that those who are down there working, as you phrased it, 12 hours a day, 6 days a week, because there was a crisis and their help was needed, are much more representative of our state employees across the board than the others. So thank you to the employees who did that, and thank you for coming to visit
Thank you,
with us.
Mr. Chairman. I will say this, and this is what I've been telling our employees when I go into our county offices. Any of those of you who know the movie Hidden Figures, I tell them they are the hidden figures that makes MDHS a success. It's not what I do, it's what they do. And the only two populations that are of concern to me are the families that we serve and the people who serve those families. And it's my pleasure to be their executive director. Thank you for the opportunity to speak to you.
Thank you very much. We'll see you all at 9:15 a.m. tomorrow.
Sir, how are you doing? You know something?
What's up?
Sitting here thinking.